WHP's operational strategy is to create a platform where an entire range of services can be provided. Primary health at the village level, and it can be escalated to secondary, tertiary health.
उनको दर्द बहुत था, दवाई दिखाने हमको बहुत ठीक हो गया उस समय से।
मेरे पास पेशेंट आता है, कंसल्ट करा के, जैसे पटना और दिल्ली के डॉक्टर से कंसल्ट करा के वहाँ से इलाज से अगर संभव न होने के कारण स्काई हेल्थ सेंटर में पेशेंट को भेजते हैं।
Through telemedicine, we see the patient, prescribe the medicine, and from there the patient got the medicine.
और हम फिर स्काई हेल्थ सेंटर से टीवी का भी सैंपल ले जाते हैं, फिर वहाँ से रिपोर्ट लाके यहाँ देते हैं।
लोग जब लेके आते हैं सैंपल और उसके बाद शाम में 3 और 4 बजे उसकी रिपोर्टिंग हो जाती है। इंटरनेट से या SMS के द्वारा हम उसको प्रोवाइड करवा देते हैं वहाँ के।
दिखाने ही आए तो हमको बहुत दर्द था, दिखाए तो बहुत ठीक हुआ।
All those are elements which will go towards creating this network and hopefully solve some of the problems being faced by the community at that level.
Welcome to the Ideas discussion. We have two panelists today, Gopi Gopalakrishnan and Dr. Jackie Linus. Gopi founded the first large-scale rural social franchising program in the state of Bihar in India in 1995, devoted to providing reproductive health services. He has been a member of India's Population Commission, advising the Ministry of Health and Family Welfare and the National Rural Health Mission, and is the recipient of prestigious civilian honor from Government of Vietnam. Currently, Gopi is the president of World Health Partners, a non-profit organization that has developed digital solutions and management systems to enable public and private sector providers to deliver standardized care and address the healthcare needs of communities living in rural and low-resource settings in India and Kenya. Gopi, thank you so much for joining us, and thank you for your time. Do you want to take a few minutes to give us a little more information on your work?
Thank you, Pallavi. Thank you for the generous introduction. Very quickly, the network you referred to, the 1995 franchisee network you referred to, that tried to identify resources available outside the public sector in order to deliver healthcare and reproductive healthcare to rural communities. So we focus both on the formally qualified providers as well as the informal providers. At that time, there was no opportunity to use any technology, etc. So purely management systems that could be used, harnessed in order to just bring better value from those resources which are already there. Later, when WHP was formed, World Health Partners was formed. In between, I just moved away. I went to Vietnam. That explained the civilian award in Vietnam. And when I came back, that was to establish a similar network of providers who could also benefit from the rapid expansion of telecommunication technologies in the world, both the mobile telephony as well as internet. But I've always been worried about this dependence on donors to continue projects because most projects wind up once the donor support is over, because you get the communities used to a way of life. And suddenly you say that the money is over and therefore we have to go home. And that is leaving them in a position which is worse than where they were earlier. So increasingly our focus is on two ways. How do you make our solutions commercially viable so that we don't have to depend on an external donor, which is probably the best way to run a program. The only problem with that is that by making it commercially viable, you're going to leave out a lot of very poor people, a lot of neglected communities who cannot afford to buy the services from a commercially viable network. Commercially viable means we don't have to make a profit, but we can't make a loss. We just break even. And that is good enough for us because we are a non-profit. So the second option is to somehow integrate ourselves with the public sector, because the public sector will never have a resource crunch. The public sector will always raise resources through taxation. There will always be a line item for healthcare in the national budget. So that's what we are building on now. And the current network, therefore, is to try to make services deliver them at a price point which hopefully be affordable to the lower income groups, but may not be affordable to the very poor. And then tie up with the public sector, partner with the public sector, in order to cater to the needs of every community, including the poorest of the poor.
Gopi, I would appreciate if you can explain just like in 2 lines these 3 or 4 key points that are mentioned on the slides?
Yeah, the first one is the logical next step of the thought I presented to you, which is how do you use resources which are already there, but extract better value from those resources by a combination of technologies and management systems. And that is the network we created through these 12,000 telemedicine centers. But that was with support from the Gates Foundation. But the moment the support was the support enabled us to provide the services at a highly subsidized price. The moment the subsidy was withdrawn, cases dropped like a stone. So what we are now doing is to reconfigure the solutions so that we can make it cheaper and also look for less investment from the front-end entrepreneurs and try to make it. So this is, as we speak, it is getting revived, and hopefully we will go even beyond the 12,000 as this project is getting set up. The second one, when we started using the same kind of approach in the area of TB, tuberculosis, we found that it immediately evoked a ready response. Even though we didn't have a clue about tuberculosis, in the tuberculosis area, especially in the private sector, the resources are scattered. There are private doctors, private laboratories, private pharmacies, private transportation services. How do you then use the thread of an electronic thread, a telecommunication-based thread, to coordinate all of them? So the moment you do that, you get immediate results. So without us really having any expertise on it, we managed to produce some, in fact, spectacular results, to the extent that the government has now expanded the model to 57 other cities. And when the pandemic broke, we repurposed the solution so that the patients could use the cell phones and connect with a doctor who may be located elsewhere. The advantage is that they could do it from their own homes. The disadvantage is that medical parameters which should have been available through a center-based approach, your blood pressure machine or meter, they were not available, but it could make do with whatever it is. The last point is we also kind of tried it to a small extent in Homa Bay in Kenya, which is one of the poorest counties of Kenya, and which is now under suspension because we run out of money, because the Kenyan model is very, very different from the Indian model.
Thank you. And I appreciate the 2 key takeaways for me from this whole description was that WHP basically is bridging the gap in 2 key areas. One is providing access to facilities that probably are not existing in rural and semi-urban areas, and also providing access to skilled professionals, also not available in rural and semi-urban areas. And you raised a very beautiful point of the need for tools to be able, perhaps some kind of portable tools that can be used in these kind of low resource settings for diagnostic. And that's a good point. I think I want to bring Dr. Linus in.
Okay.
So just a quick introduction to Jackie. Our second panelist, Jackie, is a faculty at our biomedical engineering department. Her work is mostly on the development of point-of-care diagnostics for global health. Her research focuses on human-centered instrumentation design to enable sensitive, robust, and rapid diagnostics for informed decision health making. She has co-developed mobile diagnostics, wearable devices, airborne pathogen inactivation tools, and water purification technologies with users in US, Nicaragua, Kenya, Zambia, and Haiti, and hopefully in India as well in future. Jackie, thank you so much for joining us. Can you take a few minutes and give us a little more detail about your work, please?
Yeah, I'm happy to. Thank you so much for having me. It's very exciting. I'm happy to introduce technologies in my lab, but also other faculty here at the Weldon School of Biomedical Engineering working on technologies in point-of-care diagnostics, particularly for global health challenges. So on the left side of the screen, you can see some of our work in handheld tools to detect cholera in water in field settings. That's the bottom left that says, "Welcome to Omnivis." This has been spun out into a startup company, Omnivis, that is working on bringing these technologies for water disinfection and eventually malaria, HIV, other disease detection around the world. This has gone to Haiti, to Bangladesh, and we've done a number of user trials and discussions with individuals about what it would take for implementing this type of technology. Another test that we have been happily funded by the Shah lab, has been a test for cervical cancer in a paper-based device, so that we would be able to test for cervical cancer as easy as we can currently test for malaria or pregnancy, via a simple collection of a cervical swab, and place this on the paper, and then let it run for a few minutes, and that paper strip will tell you whether there's a screening, you have screened positive for potential cancer biomarkers that would need treatment follow-up, or whether you're negative and could go on and not have to have another screening for a little while. Another test that we've been working on has been these rapid low-cost detection of neonatal sepsis and HIV detection in low-cost technologies. So both of those are, you can see that bottom second from the left image on a smartphone-based device. These look at nucleic acid amplification, which is typically done in a lab with some really expensive instrumentation and highly trained technicians, and trying to scale that down and integrate the whole thing into a paper-based device that has a readout similar to a pregnancy test and is controlled and powered by a smartphone to do all of that much more complicated processes in something that turns out to be really easy to use. Some collaborators at the Cardiovascular Imaging Research Lab are working on a wearable technology for automated detection of preeclampsia, where a woman can be screened even in her home by just looking at the difference in blood pressure when she's sitting up, when she's laying down flat on her back, and then when she's laying down on her side, and are looking at ways that we could do measurements for the difference in those blood pressures and potentially determine if a woman is at risk for preeclampsia. Other collaborators at the Natural and Biological Photonics Lab have developed a technology for assessment of anemia and sickle cell disease using a smartphone application, simply doing imaging processing and looking at the spectra across, the red, blue, green spectrum that the phone is able to capture, and then apply that to individuals at the point of care where they could be screened and treated.
Well, thank you for that, Jackie. I will now move on with some questions to each of you, and please feel free to ask follow-up questions to each other as well as we go ahead. My first question is to you, Gopi. Given that you're currently closely working with the state governments, as you mentioned, in India, and you have repurposed some of the tools and technologies for COVID-19 response, can you articulate for us what kinds of challenges are you actually facing in the current work in the light of this pandemic? And are there any specific innovation gaps that you think this current crisis has really put a spotlight on?
So when you want to go to scale, we'll have to understand two elements there. One, and this is a pattern which we see across the developing world. One, the providers, the formally qualified providers, by and large, are in big cities and in towns, like your qualified doctors. So in rural areas, you have those entrepreneurs who have become healthcare providers. It's an informal provision of care. Some of them are very good. They have acquired a lot of skills. In the private sector, to a degree, we can handle it because we can make these products available and we can get those people to buy whatever it is and use it in whichever way you want. What in economics we call the Xerox principle. Xerox can sell a photocopier to you. If the photocopier is used to counterfeit currency or to make pornographic literature, it is a problem of the person who is doing it and not so much of the Xerox company. Okay, the same thing can happen here, and that can go to scale. It'll have to be negotiated that way. In the public sector, however, we will have to have adherence to the laws of the land. So we'll have to be very, very careful, and therefore it is probably a good idea to divide them between what is possible at the front end and see if some of the complications can be taken on to the back end. If at the front end there is a little device almost like a finger scanner, and if that signal can be collected and the processing of it can happen at the back end, which is certified and which can do all those things there. Then we will be able to scale up much more rapidly in the public sector. In the COVID situation, the system was under pressure, and the best way to understand the value of a system is when it is under pressure. Absenteeism is a major issue, and not really handling the people empathetically. If you plan everything on the basis of people will be very thorough and disciplined and do their work very well, don't do that. Idiot-proof it and crook-proof it. In the sense, you will force their hand if you can get them to do things so that there is no escape. Somehow we'll have to force their hand. So this is what the weakness of those systems came to light quite sharply. But we also realized that management can play a very vital role. If you can generate system pressure through good management practices, then you can get a lot out of the same kind of resources which are deployed. But if you don't have that, and poor states normally don't have that, that's the reason why they are poor, then we will have problems.
So you said besides the challenges of the system that governments have, because we can't really do anything on that front, but the challenges of a service provider, of a social entrepreneur like your organization, you mentioned that the key thing that you think or you have observed as a gap is how the technology that is being created is being used. That part is not under the control of the creator of the technology or the service provider. And so if something goes wrong, the arbitration of where the fault is very difficult, and is very difficult, especially for the creator of the technology and the provider. But let me ask you a question. You said that the discretion of how it is being used should be very limited when it is on the user. Like the design should be such that the user doesn't have a lot of leeway in how to use it. Do you think there is an idea of training or capacity development that can be provided along with the technology? And I ask you because the technologies that are coming out of BME labs and from Purdue, Jackie, please feel free to jump in. We are imagining healthcare workers and the clinicians in local clinics using it.
Yeah, on our end, we're looking at healthcare workers and individuals who are trained, but I think it's interesting to consider that there may be healthcare entrepreneurs who don't have the formal training but would like to use the devices. And then also, it would be great if we can make them simple enough for the healthcare volunteers and community health workers who may or may not have as much training. And I love the idea of making it so that you cannot use it wrong. That's something that we've been working hard to train our students who are strongly motivated to do it correctly and to get the results they want. But to consider that somebody who is either not as well trained or not as well motivated might find ways to do it incorrectly that you never even thought of, just because you weren't designing it for them, you were designing it for yourself in another situation.
Correct. And you put it beautifully. It's both training and motivation. You may train all of them, but you keep hearing about the no-do gap. It's not that they don't do it because they don't know. They don't do it because they can get away with a simpler task. Why should they spend time and money on any of these things? Because very often in these areas, you're catering to the needs of communities which are very poor, which are not exposed to the ways of the world and illiterate, etc. So you will have to get the system to be on their side. And if I go to a doctor or a laboratory in Delhi, I'm an empowered client. That pressure is not available in those areas, in those interior areas, both urban slums and rural areas. So we'll have to bat on their behalf, and the system will have to bat on their behalf. And the way to do it is the result will not come if it is done wrongly. Okay, so they will not be able to game the system for whatever. Often it is a financial benefit. You are reusing something, reusing a reagent, or reusing a test strip or whatever it is? How do you foolproof the system so that if they want to adopt that way, they cannot function? The system will not cooperate with them. How do you do that? That is, in fact, the intellectual challenge for us.
That in engineering is part of our failure mode effects analyses that we have everyone do, which is, all the possible things that could go wrong, no matter what causes them, whether it's the device or the user or a secondary system. Like, you have to consider all of those things and how you're going to mitigate those, because that's really critical. There's only so much you can do in a lab, or even wandering around our own community, that would replicate what's actually likely to happen, from knowing the local language and the level of literacy that your users might have, to their typical customs and expectations out of their technologies. Those are all really critical aspects that we can't necessarily, we definitely cannot get sitting in our own labs and offices here.
Gopi, since a lot of your work is focused on creating systems for facilitating private and public engagement in health sector, can you outline some of the areas where you see the need for innovative tools and technologies?
Technology can be used at a facility, but we are now talking about rural communities, etc., where the technology is going to be used in areas where the human resource availability is very limited. But sometimes the use of the technology will have to be formalized by its association with a formal provider who may be available only in a city. So we'll have to understand the process. So it's, we can talk about all the things that Jackie said. They will be of enormous use, whether it's HIV or anemia. But one thing about the digital technology is that when you divide these resources in ways so that you can coordinate them, even if one part doesn't work, the whole system comes to a standstill, or it works in an extremely inefficient way, which is quite different when it comes to human beings in an analog model. Human beings can negotiate the system culturally, socially, financially, etc., and they are in situ. And therefore, we will have to pay enough attention to it. So the point I'm making is that let's understand the processes that are followed when a program is implemented, and then your engineers can say, oh, you guys are doing it in a way which is very complicated. We can do it so much more easily. Okay, but that will help us much more than to say, oh, here, take this point of care device and deploy it there. And the engineers can easily do it, but they get sensitized to the way things happen on the ground, and therefore we are able to come up with solution, which means we'll have to make that little time investment.
This is a fantastic point. Basically, as I understand, how do we replicate the current human interaction that's happening into the technology versus creating a technology and forcing processes and that specific human interaction to change? In a project I was working on the anemia technology, we were designing the technology to integrate with the tool that healthcare workers are already using. And we assumed that the healthcare worker goes to the village, collects data and comes back to the hospital at the end of the day. So the whole design of uploading that collected information was supposed to be, okay, collecting the information throughout the day and then uploading information when the device is in the network in the hospital. But when we were talking to our partner in India, in the tribal region in Gujarat, we were informed that no, that's not how it happens. The healthcare worker actually spends a week and then comes back. So there is no accessibility of the network at the end of the day. It's only at the end of the week. And that is because the healthcare worker is from that village. So that just changed the whole design.
That's one of the things that I really appreciate about the Shah Lab's support, is that it's required and expected that you be redesigning your technologies based on the user needs in the field that you are expected to visit and learn about, because it's not just a failure in global health technologies. Engineers are exceptional about designing technologies that they think will be useful without actually going out to find what people need or want. because we went into engineering because we like things more than people, some of us. But going by designing for actual human use and the workflow, which is a really critical aspect, and not just the assumed workflow, it really changes how you go about the design process, and you don't focus only on the technical specifications that you've developed, but you integrate the user needs and the process needs and the location, the other context all ends up part of that design process from the beginning.
It also works in improving processes. One is the example is the front-end workers were given these tablets for them to collect data. They were quite similar to your experience in Gujarat. But what we found was at the front-end level, and this is true both in India and in Kenya, the two countries we have experience in, and a bit of Namibia. They are very good at numbers. If you ask them to enter numbers, they do it so quickly, so well. But the moment you ask them to enter text, goes to pieces. And if they don't do it, the rest of all your work goes waste. Like UNICEF discovered in Rajasthan. 10,000 units they kind of distributed. It has completely collapsed because of this one little thing. When we found out this process, an engineer suggested, oh, there's a way out to it. Set up a call center. So we have a call center. So from the field, they just enter whatever numbers they can do. But anything which is text-based, they says call up the name, the address, etc. Immediately, the call center, which has got all of it pre-mapped, locational data, everything pre-mapped, they quickly enter it and push it. It takes them, 10 seconds to enter this data. If the person at the front end has to do it, she will probably spend half an hour for each, etc. So it works both ways.
Then we are saying that, like Jackie's technology in itself will only be providing solution to a part of the problem. But the service provider in the field has to articulate what the other outlining challenges would be so that this technology would work. I'm an engineer as well, and during my engineering teaching, it was all about the waterfall model of first assessing and then designing and then implementing and then reviewing. But what you're talking about, Gopi, here is iterative design process where we are designing one element, testing it out, and then seeing if it works, and then building on it, and then constantly doing that agile development process. Jackie, in your experience, is that the process that you have followed in the regions that you've worked in?
That is the ideal process. I think that I learned about it late, so some of the initial technologies were done in the waterfall model. And it's, but that iterative design, it's hard because you have to change your design specs and you have to adapt. And so there's a lot of pushback between people who want to just know what one thing they can solve and then go for it rather than do it properly and go back and forth with your partners and really understand, because there's a lot of stakeholders involved, understanding who's the manufacturer. And we've definitely made the mistake where we've made some technologies that are great for the end user and they fit in workflow and they do all that, but then manufacturing them is a whole other challenge because the way we designed it was not done iteratively with that stakeholder in mind. And so as we go about this process, we're trying to engage stakeholders from all different points of view and really do a much better job of that iterative design process.
I know you have worked on all those technologies, and we have been trying to sort of find out strategies for scaling and translating the technology in a way that it can reach hundreds and thousands of people for that large scale impact. Can you sort of take us through the challenges that you have faced for this kind of translation?
There's a lot of translation gaps when we're here in the lab focusing on core technological aspects of the solution, but there's a lot of avenues for collaboration and moving forward. We had talked about the iterative design process. So that comes in at every point as we're looking before we get started into insights into clinical needs and learning from our field partners, what are the technologies that are appropriate and are not appropriate that we shouldn't pursue for their specific context? What are the needs of low resource and low cost settings? Gopi, you mentioned that like $1 here is not $1 in India for your purchasing power. So when we're designing something for the right cost, that's a really critical insight as we make that one of the specifications. Mm-hmm. As we're looking into connected technologies, it's really important to understand the data outputs that are required to integrate into the workflow and into the process. So the types of data, the timing of delivery. Pallavi, you had a great story about daily data uploading versus weekly, and those are really different timelines. So another is, what type of insights does this information provide, and what can our technologies do, and how is that going to actually affect or change treatment? Collaborations are super important for the usability and implementation piloting when you get to that phase, and hopefully you do that multiple times along the development process, where you're testing out technologies with the frontline workers who are going to be using it. And another is the requirements for that scaled implementation for impact. How are you leveraging existing workflows, and how are you making these technologies work not just for a few people, but to be across the board useful? So partnerships to scale local manufacturing is really beneficial, and there's no way that I can find those partners on my own here in the middle of Indiana to find a local manufacturing partner in India unless we have partners that can connect us along the way.
Sure. Organizations like ours, when we are implementing, we make a very strong separation between M&E is normally clubbed together, monitoring and evaluation. Whereas for an implementing agency, these are two different things. Monitoring is of every single constituent in your process flow, and you monitor the performance, in real time or near real time, so that any correction that needs to be done can be done. Whereas evaluation is on a sample. So monitoring is on 100% sampling, whereas evaluation is done with a smaller sample. For monitoring purposes, what is needed is a deviation from the norm. Anytime there is a deviation, especially in the negative, that is something that has to be identified, caught, and corrected very, very quickly. But we can therefore sharpen our focus on what we want to do when we look at things like data outputs, the analytics that will come, and this will be available at a click of a button to the line managers, so that they know exactly where the trouble spots are.
Sometimes I do wonder though, Jackie, like what part, when you are designing these technologies, what part of the decision-making capability do you think is part of your design? Like, do you then also design a handheld tool to collect the data and then upload it in a dashboard for management of either government or that institute to then make decision? Like, what part of this whole process is on your shoulder and what part is on the, say, WHP's shoulder kind of thing?
I think that's a really critical question, because in our case, we look at how far along the interpretation should we be going given our particular expertise. In a paper test, like a pregnancy test, gives you 2 lines, and then you read it, and you, as the user, decide what to do with that information. So we've been looking at, simplicity and cost can be lower if you don't include the reader side of things, but then interpretation can be harder. And so what are users able and willing to do is a big question. And then once they have that information, where does that go in the workflow? What happens to that information next? And my lab, we are not information technologists. We don't have a lot of expertise, although we're gaining some more in some of the communication side of things. So partnering is really critical there too, where we can build a sensor, but that sensor doesn't do anything all by itself. That sensor has to be integrated into a larger ecosystem.
When you're talking about using these devices in areas where the care is not currently available. Often these areas have smaller populations. It may not make economic sense. Even if it is a $100, $200 product, they may not have enough of a caseload, especially from these communities which are poorer, to justify that expense. So a good way of handling it, again, technically, is to say if these two can be separated so that one mother device can cater to the needs of hundreds of daughter devices.
And that's a great idea, because then you may be able to use some of the same core technologies across settings, and then add in, you can have plug and play additions where, here dengue is going to be a problem. And so you want to be able to detect this.
Yeah.
Here anemia is a problem, but not dengue. So we don't need a device that does everything.
As Jackie mentioned in her last in her discussion on translation gaps, I think this the need for local manufacturing is a very critical area of challenge that we have come across multiple such devices. We have created, even in Jackie's work, we see there's a lot of innovative and very useful technologies, but then that's just a prototype that we have created and tested. How do we then create thousands, hundreds and thousands of these units to be usable in India in the hands of frontline workers? What do you think we are missing in terms of that translation from one technology to multiple for impact?
You're missing entities like WHP who are on the ground, because basically this manufacturing would ideally happen in countries where there's a large need, because that need will reflect in the interest of the manufacturer. I'm sure they will be interested, especially when they have a prototype available. If you manufacture in the country, your ability to market it within the country is also a little more easy. Export of that product to other countries is always fraught because you need your CE certification or your FDA clearance, etc. The country also you will need, but it is easy to negotiate through the local resource, local clearance processes. If you want to manufacture any of these, we will be very happy to get in touch with manufacturers, potential manufacturers, and put the two of you together, and you can negotiate. We can intermediate in whichever way we can. Not a problem. And plus, we can deploy it in the field, because that is something which we can tell them. How we are creating this network of 12,000 centers. So we can talk to those centers and say, this product is coming. This is how it is going to be priced, and pre-book the orders.
Yeah, that's wonderful. I think that that type of partnership is fantastic, and really one of the things that's lacking. If we go back to the challenges of iterative design, is needing to get to a place of design lock before the manufacturers can pick something up too. But if there's a way to engage manufacturers in a long-term partnership, because you have such a strong partnership with the implementation and it's worth the risk because they can see where it's going, that seems like a really fantastic process. I think you've done, like Shah Lab's done that really well with the end users, in that it's people see the importance of somebody adopting their technology, and now to be able to say, making people think about, okay, well, you have a prototype, then what, is a question that most of us haven't gotten the chance to think about and haven't been forced to think about. And so that's really good. And we're not going to have answers right away because it's new, but helping people along that path, those of us in the university, that would be fantastic.
Really appreciate that. And thank you so much for your time, Gopi and Jackie.